Hello, welcome to the discussion on dehydration. I want to start off with a few basic notes that you guys should have, beginning with normal osmolality. That's the amount of solute in our fluids, in our body fluids. The normal range is about 275 to 295 milliosmoles per kilogram. Okay, you guys don't necessarily need to memorize that, but it's good for you guys to have this as I go through this discussion. It may make things a little bit easier to understand. Also, when I'm talking about dehydration, I'm talking in generality, and I'm generally talking about sodium. Sodium is the highest particulate concentration in the extracellular fluid. And you can tell that by the normal lab value range of 135 to 145. It is the biggest amount, okay? So when we're talking about dehydration, I'm going to be talking again in generality about sodium, either excess or loss. Normal adult body weight, 55 to 60% of it is body fluids. As we age, that drops down to about 50 to 55% of body fluid, and that makes up our total weight, okay? Fluid intake, 2.5 to 3 liters per day. That's 2,500 to 3,000 milliliters per day of fluid intake. Fluid output should be 1.5 to 2 liters or 1,500 to 2,000 milliliters per day. Now, there is 1,000 milliliter or 1 liter deficit. Where does that come in? That is excreted through our lungs every time we breathe, our skin anytime we sweat, and of course the GI tract, defecation, okay? So our intake and our output should be about the same. Just remember, especially as you go into your fundamentals course, that about 1,000 of that is insensible losses. That's through our lungs, our skin, and our GI tract. Now our body fluids have two compartments that we like to keep them in. Okay, so think about it as like boxes. We have the ICF or intracellular fluid. This is fluid that is inside our cells. This makes up 2/3 of our body fluid. Okay, 2/3 is intracellular fluid or ICF. The ECF also has two more littler boxes inside of it. Okay, so the extracellular fluid is intravascular. That's inside our blood vessels. It's the liquid part of our blood. And interstitial, also called the third space. Okay, interstitial is the area between the cells and the vessels. This fluid is not readily available to be used by the body. Okay, keep that in mind. Interstitial, third space, not readily available for use. All right, so let's start our conversation about dehydration. There are 3 different kinds. I'm going to break them down and list them out individually. There's actual, okay, or hypotonic dehydration. This is where the fluid shifts from the extracellular space to the intracellular space. Mind you, this is all to maintain homeostasis, okay? There is relative dehydration, also known as hypertonic dehydration. The fluid shifts from the intracellular space to the extracellular space, okay? And then we have hypovolemic, also known as isotonic dehydration or fluid volume deficit. Okay, so let's start from the beginning. Actual, aka hypotonic dehydration, fluid shifting from the extracellular space to the intracellular space. So what causes that? Vomiting, diarrhea, prolonged fever, diuretic use. All of these things are causing fluids to leave the body, but we're retaining sodium, okay? So what happens is we end up thirsty, with a dry mouth, a decreased blood pressure, an increased heart rate, decreased urine output, and now our urine's super dark, okay? Our labs may look pretty normal with the exception of bun and creatinine. That's going to be increased, okay? So what do we do for hypotonic dehydration, which is a fluid shift from the extracellular to intracellular space? Well, if it's mild, we can do oral rehydration, okay? When I talk about rehydration, I'm not just talking about water. We need fluids with solutes. So Gatorade, Pedialyte, those types of drinks that we normally as nurses would warn people to stay away from. In terms of dehydration, we want that solute replacement, okay? For more severe cases of actual or hypotonic dehydration, we're going to go for normal saline or lactated ringers, okay? Now let's talk relative. This is hypertonic dehydration. Fluid shifting from the intracellular space to the extracellular space, okay? Otherwise, an increase in osmolality. What causes this? Extreme hyperventilation. Someone who's having an anxiety attack maybe, okay? Runners who have just pushed themselves and now they just can't catch their breath. Excessive sweating. Diabetic ketoacidosis, which is a serious complication of diabetes. Diabetes insipidus. This is a condition where the body does not properly conserve water. It leads to excessive urination and extreme thirst. Excessive intake of salt, okay, or other hypertonic fluids. So if all you drink is Gatorade, you are putting yourself at risk, okay? Neurological symptoms are directly related to the cellular dehydration, because what did I say? The fluid's moving from the intracellular space to the extracellular space. So your cells are now dehydrated. Confusion, irritability, seizures. Other symptoms are going to look exactly the same as the actual or hypotonic dehydration. That thirst, that dry mouth, that decrease in blood pressure, that increase in heart rate. Okay, so now let's talk about hypovolemia or fluid volume deficit, okay? This is isotonic dehydration. Think about that literally. Isotonic, equal parts sodium and water. So if it's isotonic dehydration, that's going to be equal losses of water and sodium. What can cause this? Excessive vomiting or diarrhea. Remember, excessive, okay? Nasogastric suctioning, excessive sweating, diuretic therapy, kidney disease, adrenal insufficiency, like Addison's disease, because Addison's causes a deficient level of both cortisol and aldosterone. Aldosterone is needed to increase the reabsorption of water and sodium. Without it, we're just losing water and sodium, okay? Burns. What happens with severe burns, right? We're not talking first degree or even like a sunburn. We're talking major burns, okay? The cells and capillaries break open. Fluid goes from being inside the cell to outside the cell, where it gets into that third space, that interstitial space. Remember, I said it can't readily be used from that space. So once it's in that interstitial space, it causes pitting edema, okay? Another cause of hypovolemia could be hemorrhage. So let's go to signs and symptoms. Increased heart rate, decreased blood pressure, thirst, dry mouth, right? Decreased urine output, dark urine. Those are the same ones that we're going to have seen before. Here are some new ones. Orthostatic hypotension, increased respiratory rate, hypothermia, hypoxia, that same dizziness, confusion, fatigue, and seizures that we saw with relative, we're also going to see in hypovolemia decreased capillary refill, cool, clammy skin. They may have really cold peripherals, so really cold hands and feet. They may be diaphoretic. They may have sunken eyes. They will have flat neck veins, decreased skin turgor. So when you go to test their skin turgor, it's going to tent, okay? It's going to stick together. What are their labs going to look like? Everything's increased. Their hematocrit, their BUN, their creatinine, their urine-specific gravity, their sodium. It's all up, all of it, okay? So how do we treat hypovolemia? Fluid volume deficit. We're treating the underlying cause. So whatever the underlying cause is, if it's excessive vomiting, if it's excessive diarrhea, we want to use normal saline, lactated ringers. If it's something like a hemorrhage or burns, we may need to use normal saline or lactated ringers plus blood products. We may even need to implement medications like dopamine, dobutamine, milrinone, norepinephrine, nitroprusside, phenylephrine, anything that's going to help expand the blood volume and get those pressures up until we can get the actual blood volume expanded. That concludes my discussion on dehydration.